Respiratory distress syndrome is the leading cause of respiratory failure in preterm infants. Its incidence is inversely related to gestational age. The earlier an infant is born, the higher the likelihood of disease. The primary mechanism is pulmonary surfactant deficiency. Without sufficient surfactant, alveoli cannot remain stable at end expiration, and collapse produces the classic pattern of stiff lungs and poor expansion. This condition was historically known as hyaline membrane disease, reflecting the proteinaceous membranes that line alveoli in advanced stages. Clinically, RDS contributes substantially to morbidity and mortality and sets the stage for long-term complications such as chronic lung disease and neurodevelopmental impairment. Recognizing its fundamental link to immaturity underscores why prevention with antenatal corticosteroids and timely surfactant replacement are cornerstones of modern neonatal care. The central cause of respiratory distress syndrome is pulmonary surfactant deficiency. In its absence, alveolar surface tension rises sharply. By Laplace's law, the smaller the alveolus, the greater the collapsing pressure, making immature lungs particularly unstable. This leads to widespread alveolar collapse, or atelectasis, which immediately reduces the lung volume available for gas exchange. Compliance falls, creating stiff lungs that require high pressures to expand. As ventilation becomes inadequate, carbon dioxide retention develops, producing hypercapnia. These mechanics explain why affected infants show tachypnea, retractions, and grunting in the first hours of life. Every breath is an effort to reopen unstable alveoli against elevated surface tension. Alveolar collapse sets off a cascade of secondary effects. When collapsed regions continue to receive blood flow, ventilation-perfusion mismatch develops, and right-to-left shunting worsens hypoxemia despite supplemental oxygen. Repeated cycles of collapse and reopening generate shear forces that injure the epithelium. This damage allows plasma proteins to leak into alveoli, further inactivating surfactant and coating air spaces with eosinophilic material that forms hyaline membranes. The process becomes self-perpetuating. Loss of surfactant leads to collapse, collapse triggers injury, injury worsens surfactant inactivation, and gas exchange failure accelerates. Clinically, this explains why hypoxemia progresses rapidly and why surfactant therapy is most effective when given before extensive shear injury and membrane formation have occurred. The mechanical and gas exchange abnormalities of RDS quickly translate into hemodynamic compromise. Poor compliance forces high inspiratory pressures, increasing the work of breathing and leading to rapid fatigue. Hypoxemia and respiratory acidosis trigger pulmonary vasoconstriction, which raises pulmonary vascular resistance. In severe cases, this contributes to secondary pulmonary hypertension and worsens right-to-left shunting, further limiting oxygen delivery. Systemically, the combined burden of hypoxemia, acidosis, and increased right ventricular afterload impairs myocardial performance and destabilizes circulation. Clinically, these infants may present with poor perfusion, hypotension, and cardiovascular collapse, illustrating how a primary surfactant deficiency can evolve into a multi-system disorder if not corrected promptly. Prematurity is the strongest risk factor for respiratory distress syndrome because functional surfactant levels are rarely sufficient before 32 to 34 weeks of gestation. In infants born before 28 weeks, deficiency is nearly universal without prophylactic interventions such as antenatal corticosteroids. Birth weight also matters, as smaller infants have proportionally less mature lungs. Sex and race contribute additional risk. Male infants are more vulnerable because testosterone delays type 2 alveolar cell maturation and surfactant synthesis, while female infants benefit from estrogen and cortisol stimulation. Epidemiologic studies also show higher baseline risk in infants of white race, though the biologic mechanisms are not fully understood. Together, these factors explain why the risk of RDS must be considered not only by gestational age, but also by fetal sex, growth, and underlying biology. Several maternal and perinatal factors directly influence surfactant biology and lung adaptation at birth. Maternal diabetes is one of the best recognized. Chronic fetal hyperinsulinism suppresses cortisol-mediated induction of surfactant proteins and phospholipids, delaying maturation even when gestational age is otherwise favorable. This explains why late preterm or even term infants of diabetic mothers may still present with respiratory distress syndrome. Elective cesarean delivery without labor removes the physiologic catecholamine surge that normally facilitates sodium transport and alveolar fluid clearance. Without this transition, residual lung water persists, compounding the instability caused by borderline surfactant levels. Perinatal asphyxia adds another layer of risk. Hypoxia and acidosis impair type 2 cell function, inactivate surfactant, and increase alveolar protein leak, accelerating deficiency. Multiple gestation raises risk through several mechanisms. Shorter gestation overall, greater incidence of intrauterine growth restriction, and in the case of the second-born twin, additional asphyxial stress and lower lung compliance at delivery. Each of these factors interferes with either production, function, or utilization of surfactant, which is why even infants who might otherwise appear mature are vulnerable to respiratory distress under these conditions. Certain conditions accelerate surfactant production and reduce the risk of respiratory distress syndrome. Antenatal corticosteroids are the most effective intervention. When given 24 hours to 7 days before preterm delivery, they upregulate surfactant protein expression, increase phospholipid synthesis, and promote alveolar epithelial maturation. Chronic intrauterine stress, such as maternal hypertension or intrauterine growth restriction, also promotes earlier lung maturation through elevated endogenous corticosteroid exposure. A more modest protective effect is seen with prolonged rupture of membranes, which may stimulate fetal corticosteroid release. These protective influences all share a common mechanism. They increase glucocorticoid signaling to type 2 alveolar cells, accelerating surfactant readiness. Clinically, recognition of these factors explains why some infants born at lower gestational ages fare better than expected and underscores the central role of corticosteroid exposure in determining pulmonary maturity. The clinical trajectory of respiratory distress syndrome follows the biology of surfactant deficiency and fluid dynamics in the immature lung. Symptoms appear within minutes to hours of birth, because alveoli lacking surfactant collapse immediately with the first few breaths, leaving inadequate functional residual capacity. Over the next 48 to 72 hours, the condition worsens. The immature alveolar epithelium is leaky, allowing plasma proteins to enter the air spaces. These proteins further inactivate surfactant, while the ongoing negative intrathoracic pressures generated by the infant's efforts pull interstitial fluid into the alveoli. The result is worsening pulmonary edema, more atelectasis, and increasing oxygen and ventilation requirements. If the infant survives this period, a diuretic phase follows. Sodium and water channels in the alveolar epithelium mature, allowing fluid reabsorption, and type 2 cells begin to increase surfactant synthesis. This transition explains why many infants show steady improvement by day 3 to 4. Without intervention, however, the cascade of collapse, edema, and inactivation overwhelms the infant's limited reserve, leading to progressive hypoxemia, hypercapnia, and ultimately respiratory failure. Understanding these stages clarifies why surfactant therapy and careful fluid management in the first days are central to altering the natural course of disease. The earliest and most consistent sign of respiratory distress syndrome is tachypnea, typically exceeding 60 breaths per minute, as the infant attempts to compensate for reduced compliance and impaired gas exchange. Expiratory grunting reflects an active strategy to preserve functional residual capacity by partially closing the glottis during exhalation, preventing complete alveolar collapse. Nasal flaring is another compensatory maneuver, lowering upper airway resistance and improving airflow. Retractions, sternal, intercostal, and subcostal occur because the compliant chest wall is drawn inward with each breath when negative intrathoracic pressure rises. Cyanosis appears in more severe cases, indicating significant hypoxemia despite these compensatory efforts. Each of these findings can be traced back to the underlying mechanics. Surfactant deficiency creates stiff lungs and unstable alveoli, and the infant recruits every available strategy to maintain oxygenation until fatigue intervenes. On auscultation, air entry is reduced because many alveoli are collapsed, leaving less ventilated lung tissue to transmit breath sounds. Fine inspiratory rales may be heard as small groups of alveoli repeatedly pop open with each breath, reflecting unstable recruitment. Blood gas analysis typically shows hypoxemia from ventilation-perfusion mismatch and hypercapnia from inadequate ventilation, progressing to respiratory acidosis. Systemic features develop as gas exchange failure worsens. Pallor reflects poor oxygen delivery to the skin, while lethargy and poor feeding result from limited energy reserve and cerebral hypoxemia. With further progression, recurrent apnea appears, signaling fatigue of the respiratory muscles. Importantly, the clinical picture can be indistinguishable from neonatal pneumonia or sepsis, both of which also present with respiratory distress, abnormal blood gases, and systemic illness. This overlap explains why empiric antibiotics are standard until infection is excluded, ensuring that infectious causes are not missed in infants initially presumed to have RDS. The chest X-ray in respiratory distress syndrome shows several characteristic features that mirror the underlying pathology. Low lung volumes are evident because widespread alveolar collapse reduces functional residual capacity. A diffuse reticulogranular or ground glass pattern appears as collapsed and fluid-filled alveoli create fine granular opacities throughout both lungs. Air bronchograms are often striking. The conducting airways remain air-filled and therefore visible against the opaque background of collapsed alveoli. In severe cases, these findings coalesce into a complete whiteout of the lung fields, reflecting near-total atelectasis. Each of these radiographic signs represents the structural consequence of surfactant deficiency and alveolar instability. Recognizing this pattern is crucial, as it supports the diagnosis when correlated with clinical findings, and also helps distinguish RDS from other neonatal respiratory disorders, although overlap can occur. Lung ultrasound provides a bedside alternative to chest X-ray and reveals patterns that directly reflect alveolar collapse and interstitial fluid. In respiratory distress syndrome, the pleural line appears abnormal and fragmented, with the absence of normal A lines that indicate aerated lung. Instead, dense vertical B lines fill the field, signifying interstitial edema and loss of air. Posterior and bilateral consolidations with air bronchograms are common, representing groups of collapsed alveoli surrounding air-filled bronchi. Small pleural effusions are present in about 15 to 20% of cases. These findings are distinct from transient tachypnea of the newborn, which shows B lines but lacks true consolidations. Ultrasound therefore not only confirms diffuse alveolar disease, but also helps differentiate RDS from other causes of neonatal distress, providing rapid, radiation-free diagnosis at the bedside. Several neonatal disorders mimic the presentation of respiratory distress syndrome, making differential diagnosis essential. Pulmonary conditions include transient tachypnea of the newborn, which typically shows delayed fluid clearance without alveolar collapse, pneumonia, and air leak syndromes such as pneumothorax. Cardiovascular causes must also be considered, particularly cyanotic congenital heart disease and persistent pulmonary hypertension of the newborn, both of which produce hypoxemia unresponsive to oxygen. Genetic and structural disorders can resemble RDS, including mutations in surfactant proteins and alveolar capillary dysplasia. Systemic conditions such as hypothermia, hypoglycemia, anemia, and metabolic acidosis may also present with respiratory distress. The overlap is considerable, so careful correlation of history, physical exam, imaging, and laboratory findings is needed. Clinically, this explains why empiric antibiotics, echocardiography, and laboratory evaluation are often part of the initial workup for infants presumed to have RDS until other diagnoses are excluded. Management of respiratory distress syndrome begins with careful stabilization immediately after birth. Thermoregulation is critical because hypothermia increases oxygen consumption and worsens acidosis. Infants should be maintained in a neutral thermal environment. Gentle handling reduces oxygen demand and avoids further destabilization of fragile lungs. Supplemental oxygen is provided to target saturations between 90 and 95%, but excessive oxygen is avoided to reduce the risk of oxidative injury. Early positive pressure support is preferred, with continuous positive airway pressure as the first-line method. CPAP recruits alveoli, preserves functional residual capacity, and reduces the need for intubation. Alongside respiratory support, fluid and electrolyte balance must be closely monitored, and sepsis should always be considered and evaluated. This approach, temperature control, cautious oxygen, early CPAP, and infection surveillance, sets the foundation for more advanced interventions if distress persists. Continuous positive airway pressure is the first-line non-invasive therapy for respiratory distress syndrome. It is typically started at about 5 centimeters of water and can be increased to 6 to 8 centimeters as needed. CPAP maintains alveolar recruitment, stabilizes functional residual capacity, and reduces the work of breathing. Non-invasive positive pressure. Ventilation is an alternative or rescue strategy when CPAP alone is inadequate. It delivers additional breaths and modestly reduces reintubation rates. High-flow nasal cannula has been studied as well, with similar reintubation rates to CPAP, but evidence is less robust for its use as initial therapy in RDS. The unifying principle is that non-invasive modalities are preferred early because they preserve spontaneous breathing, minimize ventilator-induced lung injury, and delay or prevent intubation. Selection depends on severity of disease, institutional experience, and the infant's tolerance of support. Despite optimal CPAP or non-invasive ventilation, some infants cannot maintain adequate gas exchange and require intubation. Clear thresholds guide this decision. A blood pH less than 7.20 with carbon dioxide above 65 millimeters of mercury indicates severe ventilatory failure. An oxygen requirement greater than 50% to keep saturations above 90% despite maximal non-invasive support reflects significant shunting and alveolar collapse. Recurrent apnea with desaturation and bradycardia is another indication that spontaneous effort is insufficient. For these infants, surfactant therapy is most effective when given early, ideally within the first 2 hours of life. Early dosing stabilizes alveoli before repeated collapse and reopening cause irreversible shear injury. Recognizing failure promptly and transitioning to invasive support with surfactant avoids prolonged hypoxemia and reduces complications compared with delayed intervention. Surfactant therapy is central to the management of respiratory distress syndrome. All preterm infants with significant disease are candidates, particularly when non-invasive support fails. A common threshold is an oxygen requirement of 30 to 40% to maintain saturations above 90% despite CPAP. Repeat doses may be required if oxygen needs persist after initial improvement, since endogenous production often remains inadequate in very preterm infants. The benefits are substantial. Surfactant replacement reduces mortality by about 30% and lowers the risk of pneumothorax by stabilizing alveoli and improving compliance. Clinically, the therapy works by restoring functional residual capacity, reducing surface tension, and lowering ventilator pressures needed to achieve adequate gas exchange. These effects explain the rapid improvement often seen after dosing, and why surfactant remains one of the most effective interventions in neonatal intensive care. When intubation and surfactant therapy are required, mechanical ventilation strategies aim to provide adequate gas exchange while minimizing lung injury. Volume-targeted ventilation is preferred, with tidal volumes of 4 to 6 milliliters per kilogram. This approach reduces the risk of volutrauma compared with pressure-limited ventilation, since the delivered volume is controlled despite changes in compliance. Positive end expiratory pressure is essential to maintain alveolar recruitment and prevent collapse between breaths. Permissive hypercapnia is acceptable, provided the pH remains above 7.20, as avoiding excessive ventilation limits barotrauma. In cases where conventional ventilation fails or the risk of ventilator-induced lung injury is especially high, high-frequency ventilation, either oscillatory or jet, can be used as rescue therapy. These strategies reflect the principle that in RDS, stabilization depends not only on surfactant replacement, but also on careful ventilatory management to balance support with protection of fragile lungs. Oxygen therapy must be carefully balanced in respiratory distress syndrome. The goal is to maintain pre- and post-ductal saturations between 90 and 95%, providing adequate tissue oxygenation while avoiding hyperoxia. Prolonged exposure to inspired oxygen above 60% increases the risk of bronchopulmonary dysplasia and retinopathy of prematurity by generating oxidative stress and damaging developing vasculature. Serial arterial blood gases are used to guide ventilation and acid-base balance, ensuring that both oxygenation and carbon dioxide clearance are adequate. Automated oxygen control systems are increasingly used to minimize fluctuations and reduce time spent in hyperoxia. Clinically, this approach emphasizes precision. Oxygen is life-saving in the short term, but unchecked exposure creates long-term morbidity. Careful monitoring transforms oxygen from a blunt tool into a targeted therapy. Fluid balance directly influences the course of respiratory distress syndrome. Excessive fluid administration promotes pulmonary edema, increases the risk of a patent ductus arteriosus, and worsens outcomes such as necrotizing enterocolitis and bronchopulmonary dysplasia. For this reason, a neutral to slightly negative fluid balance is preferred in the first week of life. Typical fluid restriction after the first week is in the range of 130 to 140 milliliters per kilogram per day, though volumes must be individualized. Adequate nutrition is equally important. Energy intake supports repair of injured lung tissue and promotes growth of new alveoli, both of which improve long-term respiratory outcomes. Clinically, this balance underscores that management of RDS is not only about respiratory support, but also about controlling the systemic environment that shapes lung injury and recovery. Antenatal corticosteroids are one of the most effective preventive strategies for respiratory distress syndrome. Administered to mothers at risk of preterm birth between 24 and 34 weeks, and up to 36 weeks plus 6 days in some guidelines, they accelerate surfactant protein and phospholipid synthesis, promote alveolar epithelial differentiation, and improve lung fluid clearance. The standard regimens are betamethasone 12 mg intramuscularly given twice, 24 hours apart, or dexamethasone 6 mg intramuscularly given 4 times, 12 hours apart. The greatest benefit is seen when delivery occurs 24 hours to 7 days after the first dose. Corticosteroid exposure not only reduces the incidence of RDS, but also lowers neonatal mortality and decreases risks of intraventricular hemorrhage and necrotizing enterocolitis. This powerful intervention illustrates how altering the hormonal environment before birth can shift the trajectory of postnatal respiratory disease. Respiratory distress syndrome affects more than the lungs. Prolonged oxygen exposure needed to maintain saturations increases the risk of retinopathy of prematurity, as immature retinal vessels are highly sensitive to oxidative injury. Systemic instability and hypoxemia predispose infants to necrotizing enterocolitis, reflecting the vulnerability of the gut to impaired perfusion. Long-term consequences extend beyond the neonatal period. Survivors may experience neurodevelopmental impairment, including cognitive and motor delays, due to recurrent hypoxemia and critical illness in early life. Chronic respiratory morbidity is common, with many infants developing wheezing or reactive airway disease as a result of altered airway and alveolar development. These outcomes underscore that RDS is not an isolated neonatal event, but a condition with lasting impact on multiple organ systems. Preventive strategies, careful oxygen targeting, and gentle ventilation are essential not only for survival, but also for improving long-term quality of life. RDS risk is inversely proportional to gestational age, with earlier delivery leading to greater vulnerability. Maternal diabetes delays surfactant maturation through fetal hyperinsulinism, so even late preterm or term infants may develop the syndrome. On chest radiograph, the hallmark pattern is ground glass opacities, with air bronchograms and low lung volumes. Because these findings overlap with pneumonia, sepsis, or congenital heart disease, alternative diagnoses must always be considered in any neonate with respiratory distress. These pearls reinforce the need to combine risk factors, clinical findings, and imaging to make an accurate diagnosis and guide early management.